Kurland at Baltimore is looking at using LSD in the treatment of cancer patients. This project is currently on hold at the FDA. Matthew in Durham is looking at using mescaline in healthy human volunteers and examining religious experiences. Charles Grobe at UCSD just got approval for using psilocybin in the terminally ill. Vollenweider in Switzerland is doing basic dose-response safety studies with psilocybin, and Torsten Passy and others in Germany are doing a study using healthy physician volunteers and looking at some of the neuropsychological and neurobehavior effects of psilocybin. Drugs. There have also been recent or will be studies with ecstasy, with MDE, DMT, ibogaine, ayahuasca, ketamine, and salvia divinorum. If you are interested in these studies, you can go to the MAPS website, maps.org. It's a pretty fascinating website. It has a list of all the current and recent research studies going on. And finally, we come to our own work. Our research subject is our research study is entitled Effects of Psilocybin in OCD. Started out in 1997 when the good Dr. Moreno and Dr. Delgado were seeing a patient together, and this patient had very treatment-resistant and severe obsessive-compulsive disorder. And he happened to mention to them that, gee, docs, when I take psilocybin, it tends to make my OCD better, not just during the trip, but for a period of time afterwards. So our two good doctors thought that was really interesting and got it published as a case report in the American Journal of Psychiatry. Now, psychedelic-induced relief of OCD symptoms is supported by the anecdotal evidence, because if you do a lit search, you find that there are several other case reports like this one with LSD use and with psilocybin use. It makes psychopharmacological sense that because these drugs are very potent serotonin agonists and affect that system in the brain, remember that that's the same system that we are enhancing or tweaking when we treat obsessive-compulsive disorder. So in this study, our long-term objective is to evaluate the safety and tolerability of psilocybin in human subjects. This is an FDA phase 1 study, which means that the primary goal is establishing safety in humans. And please note that we're looking these days at a primarily pharmacological, not a psychotherapeutic mechanism of action. Some short-term questions that we hope to ask. We hope to gather pilot data to point us in the right direction regarding the answers to these questions. Does psilocybin lead to a reduction in the symptoms of OCD, and that we can measure? And is a full hallucinogenic dose required to demonstrate a significant reduction in the symptoms? Meaning, does a person have to have a dose that gives them a full-blown psychedelic experience in order to experience relief of their OCD? You're just stretching?
Yeah.
So here are some inclusion and exclusion criteria for the study. Subjects have to be 21 to 65 years old. They must be prior treatment failures, meaning they have to have taken standard medications, SSRIs or anafranil, at full doses for at least a month, if not longer, and have not had a significant reduction of their symptoms. They must have no comorbid psychiatric disorders, including no active substance abuse or dependence, and no personal or family history of psychosis. They must have prior exposure to the psychedelic experience, and that's mainly for informed consent issues. This was discussed in our IRB, and it was decided that in order for somebody to give full informed consent, they should know what they're getting into. Also, our subjects have to be free of significant medical illnesses and can't be on any kinds of medications during their testing sessions. And we do an EKG comprehensive metabolic panel and a drugs of abuse screen. So this is a pilot study. We have 10 subjects and no controls. The control is built in with an active placebo. Each subject receives 3 dose levels, 0.1, 0.2, and 0.3 milligrams per kilogram. 0.2 milligrams per kilogram is the dose at which is the average dose at which most people will have a psychedelic experience. So that's the sort of threshold dose. 0.1 milligram per kilogram is a sub-threshold dose, and 0.3, of course, is a supra-threshold dose. The active placebo of 0.025 milligrams per kilogram, like I said before, is inserted to give the physiological effects, but hopefully not to induce a full-blown psychedelic experience. Our subjects, we have a very nice room up on the 7th floor. It's probably the most cozy room in the hospital. So they sit there with two sitters present at all times. They wear the eye shades, as I described, and they listen to music. Back last year, Stan Groff and other psychedelic researchers from around the country came here. Stan gave grand rounds, and we got to meet with these folks who are experts in the field, and they gave us lots of advice on how to treat our subjects, how to make the setting as ideal as possible. And so that's where we got these ideas for the music, the eye shades, and the sitters. We administer the Yale-Brown Obsessive-Compulsive Scale and a visual analog scale right before the dose, and then at 4, 8, and 24 hours. We administer Strassman's hallucinogen rating scale at 8 hours, and sessions are 1 to 2 weeks apart. Yeah?
For the 0.2 mg per kg thing, did the people who synthesized psilocybin do this and have people subjectively rate their experiences to come up with that number? Where did that come from?
That's a number that was culled from the literature and was the dose previously used in some of the early experiments, like the Good Friday experiment. They used 0.2 mg per kg. That's a good question. I don't know if they were using synthetic. Probably. We're using synthetic psilocybin. We're not using mushrooms in this because it's easier to quantify, and it also ensures no impurities are being given. So right now our results, well, we haven't broken the blind. These are very preliminary results that I'm going to share with you. We've administered a total of 13 doses. All of these doses have been tolerated very well, and we have not seen any serious adverse effects. Out of our 4 subjects, 3 had improvement in their OCD symptoms during the acute psychedelic experience, and out of those, 2 have had improvement lasting days to months after their final dose. Here are some of our funding sources that I'd like to thank now. The Hefter Research Institute, the Multidisciplinary Association for Psychedelic Studies, and the Nathan Cummings Foundation have all donated money to our research project. So he's saying, yes, I believe there's a question in the back. And I'll just put this stuff up for your perusal while we're talking about questions and such. So does anybody have any?